I'm going to talk about headaches in the emergency room. And headaches globally, they are the third leading cause of disability. And some will argue that actually you can place it even higher. And that's why we see so many patients coming in. And actually the majority will have a primary headache disorder, by and large migraine, but we always have to think about what are the secondary things that we've got to be mindful of. None of those disclosures are relevant. So, as always, I'm going to talk about Thunderclap Headache, because that's the one which automatically makes us think secondary, what do we need to think about? And the clinical signs which I think are helpful in trying to direct our thinking, as well as considering not only subarachnoid, but what about beyond that? What are the other things we need to touch on? I'll spend a few moments on treatment in the ER, and hopefully have time to just touch on future therapies which may be coming our way. Lots of phase 3 trials that are, have been published, and we're waiting on nice appraisals. So, it's often helpful to think about patients that we see. So this is a patient that I saw some time back, a 68-year-old lady, completely fit and well, a smoker, but otherwise no significant medical problems. And actually, before I met her, she'd already attended an A&E 5 days ago with a fairly abrupt onset headache. Now, she had been drinking quite a lot of alcohol. She'd been sunbathing. So there were lots of, environmental reasons for potentially having a headache. But her headache, reached peak intensity over 10 minutes. And, it was started at the back, throbbing, came to the front, more one-sided than not, and had a lot of facial ache. She felt queasy with it, the lights bothered her, she was feeling faint, and when she pitched up to A&E at that time, she was assessed, there was nothing focal. She was reassured that this was probably a migrainous attack and given codeine and paracetamol and discharged. However, 5 days on, she still has a severe headache, which is there all day, worse in the morning, and actually she's not eating because she's vomiting so much. She has neck stiffness or neck pain. She's very light sensitive. And when she arrives back in the country, she faints at the airport. A simple faint, but she faints. She pitches up at A&E, and actually examining her, the neurology is very unremarkable. She does have some nuchal rigidity, and her temperature is 37.8. There's a suggestion that she's lost quite a bit of weight just from dehydration through vomiting, and she is tachycardic and hypertensive. I think we see these all the time. And I think the first thing that jumps out to us is, well, what is the profile of the presentation? And we're all looking for that thunderclap event. And whilst this isn't instantaneous, it took 10 minutes to reach its peak, there is no question that this is not something that any of us would feel comfortable with. She didn't have a prior history of migraine, so really this is a recent sudden onset, very severe headache, which is, if anything, getting worse. I put that there really just to remind us that there are some French guidelines out there about headache in the emergency department. And I think that's quite useful because looking around, we don't have that many guidelines to actually refer to. So we are either faced with a patient who is comatose or actively seizing, and those we know that we've got to pay particular attention to. But, there are clinical signs which can be really helpful. And I have to say, I think the eyes have it. So I'm going to put up some pictures. The first one is ptosis and conjunctival injection. The next is a Horner's plus. The next is a sixth nerve palsy, plus or minus papilledema. And the next is a subhyaloid hemorrhage. And this comes down to you. So I want you to get ready, because we're going to vote on the app now. I'm going to show you some diagnoses. So those are the different diagnoses I want you to just match to the clinical sign that you're seeing. So A would be subarachnoid, B would be venous sinus thrombosis, C would be cluster headache, and D, an arterial dissection. So let's start with number 1. I'm hoping not to give it away. Yeah. So if you would like to vote now, I'm just going to give you 30 seconds because I want a snap decision. What are you thinking? Everybody voted? You know where to vote. It's the neurology session and active voting. Fantastic. So it looks like the most popular is, we're still is option C. So, okay, so C was the biggest. I've got to try and remember what that was. Unfortunately, can't go back.
Cluster headache, isn't it?
Okay, so it was cluster headache. Great. So, you know, why cluster headache? Well, you've obviously got autonomic signs. You've got the ptosis, the red eye. It's all very much, you know, one-sided. You'd be looking in the history for somebody who had, you know, episodes of headaches. Although it may be thunderclap, had they had other episodes? Are they having more than one episode attack in the day? You would have to think about other differentials, which I didn't put there, but things like acute intermittent glaucoma. We've had patients that we've treated for cluster headache, they haven't responded, and we've had a case where it was actually a glaucoma case. So let's go on to the next sign, which was a Horner's plus. If you want to vote now, those are your choices. Okay, so if we have the information, all of you went for option D, which, well, those are, well, 3/4 at least. So if we move on to the next slide, perfect. So yes, you know, I'm glad that all of this is, you know, second, you know, hand, because I've certainly seen patients where it's been missed, that people are not putting things together. So Horner's can be very subtle. And often you go back to the history and ask them about the pupil irregularity, you know, at the time, you know, that they noticed that there might have been some eyelid droop. And actually that can be more helpful than seeing the ptosis yourself. This patient also has not just a Horner's, but he's also got lower cranial nerve involvement. So you can see the tongue is deviated on that side. And that's very typical. So the majority of these patients will have headache. About a fifth, it will be thunderclap. And you're looking for everything to be ipsilateral, the craniofacial pain, as well as the neurological signs associated with that. And obviously, because you're worried about sort of like your lumen becoming narrowed, these patients are at risk of ischemic events. And unfortunately, when you're mistreating them early, that can be the consequence. Okay, the next one is the 6th cranial nerve palsy, plus or minus papilledema. And those are your choices, so if you want to vote now. Perfect, good. So that one I think was, if we move on to the next slide, sorry. So that one hopefully was, you know, very familiar to people. We think about it in terms of venous sinus thrombosis, but also, you know, we think about it if a patient had idiopathic intracranial hypertension or even a space-occupying lesion, because by and large, you know, venous sinus thrombosis can present as thunderclap. The other ones are less likely to, but it's all to do with the high-pressure state. And the headache, you know, reflects that. So you're looking for the postural association, getting worse with Valsalva, the visual obscuration down to the papilledema, as well as sort of like pulsatile tinnitus, etc. These patients can have bilateral brain involvement. So again, you know, we're seeing patients who may have bilateral motor deficit, and seizures are a significant proportion of these patients. Now, the next one should be straightforward, and in fact, we've given it away, because by definition, we've excluded all the others, so I think the majority of you would have plumbed for that one. Now, subhyaloid hemorrhage, I can say that I haven't seen patients that frequently with this. But the important thing is, in the context of a thunderclap headache, it's almost pathognomic of a subarach, so it's really helpful. So we keep on harping on about the importance of looking in the eyes. Well, you know, if you get that and you've got a thunderclap headache, you can start treatment. You can start, you know, changing, you can get in touch with the neurosurgeons before you've got any tests back. The majority of these, as you know, are berry-aneurysms, which have bled, and you get the meningeal irritation from the blood load that patients have. So headache can occur in isolation, but it's also notable that, you know, we've talked about some of the things that may be there. Transient loss of consciousness is fairly common in this group, so it should just be a flag. Again, you know, don't be distracted by things like delirium and seizures and not think about this, because we've certainly seen patients presenting in that way. So that's just the signs that I very much think are helpful in our thinking about patients presenting at the front door with thunderclap. And we can automatically start changing how we're investigating these patients if we're seeing those signs, and this is high on our differential. I did put here just a note about the meningeal irritation. I described her as having nuchal rigidity, and I think, often we talk about, the signs which can be helpful in determining this, namely Koenig's and Brudzinski's. But these ones really reflect the involuntary flexion that patients have when you start to stretch their meninges. And that is not always what people mean when they write nuchal rigidity. So in migraineurs, they often get a lot of surphagalgia, and in that regard, they can also have quite a bit of neck stiffness. Those patients, when they move their head from side to side, they don't like it and they will resist it. So I think it can be helpful if you've got things like Koenig's and Brudzinski's, but often, you won't see these, so it's not useful when it's not there. The images below, that was just to remind you that actually, when we look at subarachnoid hemorrhage and we look at meningitis, this is obviously an MR, that's a CT, but you can see, that's comparing to the normal MR, that actually, you'll find that the blood load or the inflammatory changes are in the same place, and that's why they can be very difficult to distinguish between. We also know that patients with subarachnoid, particularly when they're well into it, can be pyrexial, and that's a central pyrexia rather than infection. So I think it is just, worthwhile also not being side-railed by some of the features that you will see. If we return to our case, we all knew that this was a case to worry about. There were many flags that we would consider, least of all, her age and the fact that she's never had a headache history previously, and the abrupt onset and trajectory would make us, try and determine what's causing this. It's sort of like in the ER, obviously there are a number of different potential scenarios. I've highlighted the one that we would immediately go to, which is thinking about cranial and cervical vascular causes because of the thunderclap nature of it. And, there is Perry's group in Canada, they did a lot of work in terms of coming up with the subarachnoid rule, the Ottawa subarachnoid rule. And I think, it has value. It's a risk stratification tool. It's usually useful when you think, I'm not worried about that patient. Should I be? And then you just go through it to check that they're not sort of like ticking off any of the variables which would put them in a higher risk category. It can't be applied to people who have previous headache or have had aneurysms or have had, traumatic injury. So it's a very specific group of patients, but it is a way of just, when you know that you're moving on from a patient, you've just sort of like cross-checked things. This was our patient, so she had, 5 days on, quite a significant blood load, and, surprisingly, from the neurological perspective, she was actually relatively well, in pain, but her level of consciousness was not affected by this. 5 days on, the value of CT, well, we know that that's a tricky one. We know that at a week, the CT will miss it in 50% of cases. And that's sort of like quite an old timeline that people, studied, but I think it's still what we stick to. We know that, the lumbar puncture is still very valuable, and that up to 3 weeks, it can be very helpful if you're looking specifically at spectrophotometry and xanthochromia. But there is a movement to say, well, can we not just rely on the CT early on? And I think, a lot came from, again, the group from Canada were trying to look at what happens with those that we're scanning as soon as they come in the door, so at under 6 hours. And in that group, they didn't find anyone where the CT did not demonstrate subarachnoid blood. I think it has to be taken with a note of caution. This was in a university hospital and a tertiary setting with quite, they have dedicated neuroradiologists, so that was, definitely the case in this group. And the reality is that when patients come to us, we're lucky if we get them at less than 6 hours in this country. And the other thing is that a lumbar puncture is not just about saying they don't have subarachnoid. It gives you a lot more information. So I think it's a very useful study, and I think it's useful when we're faced with patients who really, you're not so worried about and the patient does not want a lumbar puncture, because at least you can share that evidence base with them. Another group in Leiden recently looked at, well, can we do a CT angio instead of an LP? And so they took patients who hadn't had, who had basically had severe non-traumatic headache. They'd already had a normal CT. Their neurological examination was normal, and they CT angioed all of those. And, they picked up 7% of vascular abnormalities, but at the end of the day, only 1% or 1.5% were felt to be actually relevant. So again, it's this, it can be useful, but there's always the question mark of whether what you find is relevant to the headache that you're seeing. I'm standing here talking about subarachnoid to an audience who know already a lot about subarachnoid. You are the people who see them. But the National Confidential Inquiry into Patient Outcomes and Death, which was in 2013, flagged that we need to be doing more, that our care is not as good as we think it is, and actually is quite alarming in terms of the percentages. From a clinical perspective, they felt that 30% of cases we could have done better by the patients. And it's clear that in primary care, this is still something which is very significantly underestimated. And when people are coming in the front door, 20% are not being examined, or at least it's not being documented. And I think we've already clearly seen actually how those clinical signs will change the way we think. At that time, there was also not standard protocols within departments for managing these. And I think, beyond subarachnoid, I think, there used to be a point where we would get, we would stop saying, well, we've excluded subarachnoid, let's see how the patient is and discharge. And I think the value of thinking about this is actually, we know that our normal routine is CT head and LP. If the LP is abnormal, well, then that helps us because it's diagnostic. If the initial imaging is abnormal, well, then that helps us because it gives us a diagnosis. But we've got to think about, well, the normal ones, where do we go with those? And I think then you go back to your history. You know what patients with different types of pathogenic etiologies, the flavour of their history, what it will be. So you go back and you interrogate that, and you look for any of those signs that we've already talked about. And then that will guide you as to, well, do I need to do more imaging? Are there other tests that we need to be doing? And really to remember that Thunderclap headache has a much larger potential differential than subarachnoid alone. And these patients often are the ones which stay in hospital and their diagnosis can be delayed for a number of days. I'm not really going to say much on this. We've talked about Thunderclap. I haven't mentioned idiopathic intracranial hypertension and those patients who are shunted and where clearly they're coming in with the exacerbation of shunts, exacerbation of headache. There's some excellent guidelines. So there was an IIH consensus guideline group, Alex Sinclair and Susie Milan. They've done a wonderful paper which really reinforces that when it's headache alone and the vision is not changing, then you should assess them as you would anyone else. So obviously because they've got a shunt, you want to think about infection, but otherwise, think about the type of headache they've got. So moving on to treatment in the ER, we said that actually the majority of these patients will be migraineurs. They will have a primary headache disorder. And I think it's often useful to just try and think about the treatment we're giving the patients and making sure that that is what we're really targeting, because we know these treatments work in the other secondary headaches. This is a table not to really read in detail, but simply to point out that for things like paracetamol, the non-steroidals, the number of patients that you'd need to treat to get one patient pain-free at 2 hours is in the order of 7 to 12. Now, prochlorperazine, metoclopramide on their own have an antinociceptive component, and whilst it's not tremendous, you'd have to treat 17, it still is notable. And the studies have looked at combining it with some of our ordinary approaches, paracetamol, aspirin, and suddenly we're finding that combination is as effective as high-dose sumatriptan. So I think that really is a very useful thing, and we need to be mindful of it. So those are sorts of the treatments that we'd want. We want patients to have the best chance of responding to the treatment. So I consider sort of like we're wanting a number needed to treat less than 5. So the antiemetics, the antidopaminergic antiemetics, given intravenously if need be, together with your choice of basic analgesia. And of course, not forgetting sumatriptan and trying to put that into the equation quickly. Many of the patients have opiates, they're given opiates, and I think this was a really useful study in 2017 by Friedman's group, which tried to compare hydromorphine to intravenous prochlorperazine. And actually this study was halted, so they'd managed to recruit 200 patients, and it was stopped because there was a clear superiority of IV prochlorperazine. And you were seeing 60% of patients pain-free at 2 hours versus 30% in the hydromorphine group. And so I think really, there are many reasons why I don't like opiates as a headache doctor, but also we know that there are treatments out there which are much better and should be used. So that's the sort of line of approach that I would be, recommending, that in patients, not with migraine, but in patients where you're worried that you don't know what the underlying drive is, so you're going to avoid things like the non-steroidals and aspirin, then, you're going to stick them with a lot of fluid, you're going to give them intravenous prochlorperazine and paracetamol, and then once you've had a chance to assess that patient and you can be happy that there are no vascular risks, either from their comorbidities or indeed, what you think could be driving the headache, then you can add in sumatriptan. And then once you know that hemorrhage is not in the equation, then you can go back and actually start using some of the non-steroidals on a regular basis and try and leave codeine away as much as possible. However, I should say that, this is, a good time to be a consultant with an interest in headache because there is a lot of research interest and a lot of change on the horizon. A lot is going to be governed by cost and cost economics, but I think we now have several drugs which are at phase 3 and may well be entering our treatment arena very soon. So lasmitamine is very similar to a triptan in terms of its efficacy, but instead of targeting what a triptan targets, it's still serotonergic, but it's the 1F, and it avoids any vasoconstrictor problems. So you can imagine if we didn't have that, then this could be put in very early on in terms of treating patients. Its 2-hour pain freedom is as good as a triptan, and also response to it does not seem to be predicted by your prior response to the triptans. Those are the 2 trials, Spartan and Samurai, recruiting, I think in total about 2,500 patients, and they're clearly showing the efficacy. So watch out for that one. The other new thing on the block is CGRP. I say new thing, it was first identified back in the 1980s, so it's taken quite a while. But we know it's really critical to the pathophysiology of migraine. We know that when people have a migraine attack, the CGRP levels shoot up, and if you can effectively treat that migraine attack with sumatriptan, you stop those CGRP levels rising. If we gave a migraineur an infusion of CGRP, they would get a migraine. So we know it's incredibly important. It locates to the trigeminal ganglion and is important in the trigeminal-vascular reflex. And so the new thing is, can we block this, and what would be the efficacy of doing so? And this, effectively shows different ways of doing it. We've got monoclonals coming forward, which either block CGRP or block the receptor. And we've got a new group called the GPANTs, which have been around for some time at a trial level, but with problems with liver toxicity. However, they are coming out now without those problems, so we're seeing them. So this is just probably in the last, in the last year, the trials that have come to phase 3 and are out in the public domain. The CGRP monoclonals, irenicimab, I can never say these, fremanezumab, galcanezumab, and eptinezumab. They are subcut injections, all of them apart from eptinezumab, which is intravenous infusion, and the GPANT that we saw previously, the one that is coming forward without the issues, is Subarachnoid. If we think about that one first, well, actually, it is showing good efficacy. So the grey bar is the placebo, the blue bar is the higher dose. And whilst, it is a lot of work is still ongoing with this and ongoing in terms of the time frame, What is clear is that it's having an effect very early on. So this is again looking at 2-hour headache freedom. So I think that will be something which I'd look forward to in terms of thinking of being able to use it. These are all the phase 3 results of the other monoclonal antibodies, and they're looking at groups of about 1,000 patients, and what you're seeing is between a 40 to 60% response. The grey bar is the placebo, and we know it's high, and placebos where you've got injectables are always going to be high. But I think the other key thing is that when you look at the maximal time to response, you're seeing within a day of the infusion that these patients can already declare themselves. So, in the future, we would like to think that if these did get a place, if they did get sort of like funding, we would be able to integrate these into what we're treating patients with at the front door, and potentially really limit patients' recurrent attendance or indeed the length of the hospital stay, as well as having a greater impact on their disability. So with that, I will stop, and I'd be happy to take any questions.